TopMedTalk.
Hello there. We're back with TopMedTalk at SCCM, or the Society of Critical Care Medicine, here in Orlando, Florida. We've had the opportunity to catch up with a friend, Professor Manu Malbrain, to talk to us about fluids and the ACS, the Abdominal Compartment Society, that he is able to spearhead, or you have spearheaded and joined. But Manu, thank you for coming back and chatting with us.
Yeah, pleasure being here again.
Well, to tell her, this is part 2 of our conversation that we've had here. So, Manu, we just spent the last, 30 minutes or so talking about all the amazing work that you've done in our space of critical care medicine and medicine in general, management of fluids and abdominal hypertension, compartment syndrome, all those things. But we wanted to take this opportunity and talk to you, not necessarily as Professor Malbrain, who is out there disseminating all this wonderful information across the globe, but as the patient, Manu, who has experienced some of these things that you have been lecturing and talking about your entire career. So if it's okay, we'd love to be able to hear a little bit more about your experiences in this space.
Yes, it's a different angle.
Yeah, let's put on take off the hat of
instead of being the doctor treating the patient, I also was the patient being treated. Quite unexpected. I underwent major surgery, and of course, after the surgery, was admitted in the ICU, intubated, ventilated, sedated under the opioids.
Yeah.
So I remember waking up with the tube, not able to speak, and hooked at the bed.
Oh, like
restrained?
Yeah,
restrained so that I could not extubate myself accidentally. I heard some nurses talking over me about we're going to put him on spontaneous to see if we can take the tube out. And that I remembered as something, you have to breathe. So I start breathing. Of course, because of the morphine, you stop breathing.
Yeah.
And you're waken up by the apnea alarm of the ventilator.
Yeah.
Eventually the tube got out, and in front of me was the clock. I think it was about 1:00 in the morning, and I asked to call my wife, who was devastated because she was not expecting a call at 1:00 in the morning from the hospital, because she recognized the number being coming from the hospital. So I just wanted to say her, I'm extubated and everything is fine. So that was okay. But I remember the clock. So it was 1:00, and then 5 minutes passed by. For me, it was the impression 2 hours. Of dramatic dreaming, hallucinating, whatever. And the whole night I saw 5 minutes by 5 minutes, the clock passing by. Very, very strange. So then the painkillers stopped having their effect. I got 4 chest tubes, which were very painful whilst breathing. So they tried to do some infiltration locally. But what I recall is that sometimes people enter the room not introducing themselves. So it all the little things in the communication between healthcare provider and patient. Basically, that's all you need.
Mm-hmm.
Someone coming in, introducing and explaining what is about to happen. So there was discharge to the surgical ward, where they came with 1 tablet of paracetamol. And I was looking at the tablet, and I said, I'm not going to make it through the night.
Tylenol, yes. Acetaminophen.
So, what I did is I phoned my friend, and I said, this is not going to work. I need something stronger. But the point was that he called back to the nurses, and suddenly I had 3, I can understand, 3 angry nurses at my bed, because they said you have to call us instead of fully understand. But that made the relation maybe more complicated. At the end of the day, the anesthetist came and gave me some intravenous paracetamol, some intravenous ibuprofen, and some oral opioid tablets like OxyContin, surrogates like that, with a limit amount I could take, but it made that every 2 hours there was a pain relief, and you're really waiting to get something for the pain, because breathing was quite painful. So I realized when I was put a couple of days later on the weighing balance, that my body weight was increased from about 85 kilos before the surgery to about 92. And I remember that I asked my wife to take some pictures of some bags of glucose plus saline, so abnormal saline 0.9%
yeah.
that was administered. So I guess it must have been the surgery, maybe some inflammation, some leaks, some fluids administered, so that there was accumulating some fluids. So I got some diuretics for that. But the fluid accumulation made that my chest wall was stiff, my abdominal wall was stiff. With the opioids, I had abdominal distension. And even to the level of abdominal hypertension, not a compartment syndrome, maybe close. So I could feel the mechanical interplay from the increased pressure in the abdomen that was pushing the diaphragm upwards, and I was almost not able to breathe. I was starting to cough, which is the last thing you want to do after major surgery.
Yep.
So I called the nurse, which I was told to do.
Yeah.
And the nurse said, okay, we can't do anything. The doctor needs to decide. I said, call the doctor. I remember, I think it was a first year resident surgery.
And Manu, sorry to interrupt. This is a hospital that you're a doctor in.
No.
No.
Oh,
so you had a little bit of a lucky break.
Yeah. No. So I asked the medical trainee, I think it was first or second year, pick your stethoscope and listen to the abdomen if there is something, clangor or bowel sounds, if there is ileus and so forth. But it didn't have a stethoscope that I remember. I told him, I think I have fluid accumulation syndrome because of that poor compliance and because of the opioids, abdominal distension, hypertension, and you need to do something because I can't make it through the night. So then the nurse came, saw my belly, and I got a decompression with a tube. I'm not going into detail, but that was instant relief. And there were some minor complications related to that afterwards. So it was a very interesting experience. And I would recommend every doctor, healthcare provider to be a patient.
Yeah.
Because then you realize that it's in the little things that you can appreciate the care, the comfort, and the treatment. So it's just a little gesture, just a communication that makes life much more easy.
Yeah.
Being a patient,
Yeah. Working in the critical care and in the hospital and the OR now, we, at least in the US for us, it's a lot of production pressure. And there's you're taking care of a lot more patients now than you ever did before. And it's all about, for the OR, churning and burning as many cases as you can get through. And in the critical care, you're taking care of, 3 or 4 patients whenever you should be taking care of 1 or 2. And so I think a lot of care clinicians have sometimes forget, like, we're actually taking care of a patient. Yeah. They're a person. And it could be, it's a mom, dad, family member, child of somebody, so like we need to do that. And I think we've maybe sometimes gotten away from it.
Yeah, exactly. I think it's being a blessing to be able to be a doctor and to provide care to other people and patients. I think we should be very humble and always ask ourselves, how do I want to be treated if I would be a patient at this time?
Yeah.
And then it's not just the elaborated differential diagnosis or technical investigation, but it's just the little things and the human factors. So the non-technical skills, they are probably more important.
How much of a patient reported, symptomology or reporting their symptoms do we need to listen to? Because it sounds like you knew physiologically what was going on, but you also were saying, oh, I'm having a lot of abdominal pain. I'm having a lot of pain, a lot of splinting. I can't breathe. Should we be listening to? Because I think some of that gets dismissed sometimes with our patients.
Yes, it's a good point because, of course, I'm biased. So I knew the symptomatology and I translated it and tried to explain what was happening. But I assume that many patients are not aware and don't know what is happening. And they were told it's normal, it's post-operative, be patient, be brave, and so forth. So, yes, I know what you're saying. And I think we should listen more to the patients, also to the relatives. Sometimes They spend more time with the patient than the caregivers can, and it's sometimes very interesting and important information. I just finished a master after master in insurance medicine, which is all about dealing with medical complications. We call it medical accidents, where something happened and the course of the disease changed and maybe the patient even died. It's a thin line between a normal complication or a medical error that results in the death of a patient. But I think at all times, there should be an open disclosure to the families where we can explain, we did this complication or whatever happened, and this resulted in a course of events. The problem is, at least in Belgium, the doctors are insured against these kind of medical errors, but they are not allowed to admit that they committed an error, because then the insurance company will not cover, and the doctor is liable for what happened.
See, back in the UK, where we start with Crown indemnity, so this state insures the National Health Service doctors, we have a so-called duty of candor. So we must disclose even something that didn't result in harm, that something could have caused harm. And we're supposed to disclose it in writing.
Before, after.
In other words, after the event. In other words,
So you have the informed consent before.
If I gave you the wrong drug but nothing bad happened to you,
you have to disclose.
I'm not sure in reality how effectively that happens, because it's a lot of extra work. But I'm supposed to communicate with you as a so-called duty of candor that you were exposed to potential harm that didn't translate through to harm.
I think that is the right way to do. If you can rest assured that the family and the relatives will not use this against you as a caregiver, because then it would not be a solution. And I think this open disclosure basically allows caregivers, patients, relatives, and maybe a lawyer from the insurance company to sit together and to discuss what happened. And this remains within the confidentiality of the patient record, and can also not be collected afterwards in court or used against you. And I think this is a way to go, because most of the relatives, they just want to hear something wrong happened. It was not our intention. We tried to do everything we could to correct it. We checked our internal policy and protocols. We adapted them. We learned from it, and this will never gonna happen again. This is basically what the family wants to hear.
Absolutely. So two things. One, from the U.S. perspective, it's very complicated. There's a lot of legalities around that, and we're a very litigious society, no matter if there are protections in certain states for clinicians or not. It's very complicated. But as a quality person and as someone who sits on the Anesthesia Patient Safety Foundation and all those things, I firmly believe that we should be disclosing whenever things happen to our patients and be able to, one, for the patient, let them know and their family, but two, for us as clinicians to understand, what are we doing? How can we avoid iatrogenic harm? As I think you started off the podcast earlier saying, how do we do that? And we can only learn by the errors that have gone before us.
Absolutely, because there's not only the first victim, the patient who died or had a complication, but also the second victim being the caregiver that may suffer from the fact that he did something that caused this kind of complication. So, at least in Belgium, there is still a long way to go to safe incident reporting, to discussing it in a morbidity, mortality stuff, to learn from it and to have this open disclosure thing.
Smile. Pictures are you taking? That's great. Manu, thank you for sharing your story with us. You look fantastic now, and you're healthy, and
my heart is beating. Yeah, it was funny.
It's a good thing. Last time I checked, what a wonderful story, and a lot to learn, I think, from your experience. Hopefully, our listeners can take
this
a little
was
away.
Just, I would say, a minor thing compared to patients with COVID who stayed in the ICU for weeks,
Yes.
if not months, with a trach and
Yeah.
totally paralytic
Yeah.
without the possibility to move because of critical illness, polyneuropathy, or post-intensive care syndrome. So this is a whole other thing. So this was
Absolutely.
just a surgery that was perfectly
Yeah.
done, but with the things that
Couple
are normal
things. Yeah.
and that can happen. And how it impacts being a patient, for me, was not a problem because I understood.
Yeah.
But I can imagine for
The majority of people.
the majority of patients that would be very stressful. And
Yeah. We've talked a little bit about this on Top Men Talk, Monty. I know you've done some work about critical care. What's the paper that you published on critical care and it was worse than torture?
It was relating it to torture, which has been written about a number of times before, originally written up by a critical care nurse, is that much of the features of critical care align with the World Health Organization's definition of torture, which is, it's a very stark thing to, like your hands were tied, you were cuffed to the bed.
Yeah.
Yeah,
You know,
that's what we do.
Your dignity was taken away. You were kept awake inadvertently, so you were sleep deprived. You know, it's not intentional.
Yeah.
That is what we do.
Yeah.
Exactly.
Maybe the opportunities for ways to look at ways
Yeah,
we may not do that.
Pause, look at it, and think about it.
Yeah, absolutely. All right, guys. Well, we're going to wrap up. Thank you so much for taking the time to sit down with us.
Pleasure.
Yeah.
Thanks, Desiree.
Absolutely.
Monty.
Great to see
Thanks
you.
for hanging out. And thanks for listening to Top Med Talk. You know, you can always find us at topmedtalk.com and check out Professor Malbrain and all the great work he's doing with IFA, IFA, and the
WSACS.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EdPom, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is edpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. edpom.org.